Thank you, Dr. Katula. And I just got a little late. I just flew in from Washington D.C. back and just made it home. It gives me immense pleasure to introduce our speaker for today, Dr. Srividya Kidambi. She's a professor of medicine and chief of division of endocrinology at the Medical College of Wisconsin. And she graduated from Gandhi Medical College, Hyderabad, completed her residency in internal medicine at SUNY Buffalo, and fellowship and master's in epidemiology at Medical College of Wisconsin. Nationally recognized for diabetes and obesity work that she's done, and she also serves as Associate Chief Medical Officer for medical and procedural specialties out there, and actively engaged in weight loss programs. A fun fact that she shared with us was that she regularly solves the New York Times crossword puzzle, which I also do, but the easy ones. So I'm pretty sure, yeah, you're at a different level altogether. And she's worked up consistently completing the Friday puzzles and cracking the notoriously tough Saturday and Sunday editions. So look forward to that. And also to moderate the talk, want to welcome Dr. Preeti Kishore, who is a professor of endocrinology at Albert Einstein Medical College in New York. And we welcome you both and looking forward to your talk today.
Thank you. Thank you for that kind introduction. And thank you, Preeti, for agreeing to moderate. I'll go ahead and get started. As Dr. Govil mentioned, this is really at the forefront. It has touched everyone's lives, whether you practice obesity medicine or not. My talk, I think with the quote unquote Ozempic, that's what exploded on the scene. But those of us who have been in this field before Ozempic ever became popular and it was cool to be, now everyone wants to do obesity medicine. It was funny today, there were surgical grand rounds on just an external speaker just talked about Ozempic or something like that. So it's really cool now. But some of the things I'm going to talk about are not cool things, but really what led to the cool status now. So bear with me as I talk about boring stuff, which are extremely important to manage patients. So the pathophysiology of obesity is extremely important to understand management and how to maintain the weight loss. I'm going to touch upon each of the modalities of management. And as you can imagine, each one of them can have several hours of discussion. But just important things to keep in mind will be covered. And I'm not really going to talk about surgical weight loss today. So the key part of obesity, for understanding obesity, is that it is a health condition. It's not vanity. It is not related to someone's desire to be a certain weight to look good, but it's a chronic, progressive, relapsing, treatable, multifactorial neurobehavioral disease, because that's the crux of understanding how to manage this. So believe it or not, this field is extremely young. So up until 1998, we did not even have a definition for obesity. If you looked at publications before late 1990s, every publication used different types of definitions. In about 1998, NIH convened a panel to come up with the definition of what it means to be overweight or obesity. That's has been modified because the BMI cutoffs that were generated were purely based on Caucasian populations. So we now know that the BMI cutoffs may be more appropriate based on gender, race, ethnicity, and menopausal status. Very important for our community, for Asia Pacific communities, the BMI cutoffs should be much lower because of increased visceral fat, and that they develop weight-associated conditions at lower weights than other ethnicities. So as if you can see, the normal range for Asia-Pacific ethnic groups is between 18.5 and 22.9. So that means the BMI over 23 is considered overweight. And as you can see below, in that third column there. So you can see class 1, class 2, class 3 obesity definitions are different than NIH definitions, which are mainly for North American and European populations. These BMI cutoffs again, the risk can be modified by the waist circumference. So it's not news to any of us, but I think it still is not practiced that way. So most of the practitioners do not really treat Asia Pacific region inhabitants in a same manner, in a different manner. We need to take it much more seriously. So just a little fun graphic that I like to show. Why BMI of 25? So I did mention it's mostly for Caucasian populations, but it is comes from the studies like that. So the mortality risk in American Cancer Society cohort showed that in all age groups, in both men and women, except in elderly between ages of 75 and 84, the mortality rates increased after the BMI of 25 and much more so after BMI of 30. And so that's how they have been defined. And the disease risk, for example, they looked at type 2 diabetes, gallstones, hypertension, and coronary disease. Again, showed the same thing in women in nurses' health study, in male physicians and health professionals follow-up study. So that's the background behind picking up those cutoffs. Again, there's nothing magical between 29 and BMI of 30. It is a continuum. So all we have to remember that these cutoffs were given so that practitioners had something to look for, right? There is no significant difference that magically happens when the BMI moves from 29.9 to 30. So it's important to understand the context. So obviously BMI is an imperfect measure. It doesn't really distinguish between fat mass and muscle mass. As you can see, 1 pound of fat weighs much less and occupies more space than 1 pound of muscle. And again, it is not a perfect measure in smokers who have low BMIs, and then those with underlying illness and elderly. And of course, ethnic differences are important as well. Now, there is a unapproved or not scientifically validated expert opinion-based cutoffs based on percent body fat that sometimes people use just because of the imperfect nature of BMI. But for all practical purposes, for us as practitioners in the clinic, BMI really does serve a good purpose. There are a lot of data to show improvement of BMI is associated with improvement in a variety of cardiometabolic risk factors. So it's still a good one, but important to understand. So there is a sort of the definition of a subset of patients of obesity, adiposopathy versus fat mass disease. So many of us have seen people who have 300, 400 pounds and have no diabetes, no high blood pressure, or dyslipidemia. So it doesn't mean that they are not necessarily sick. In some sense, many of the medication approvals are only achieved if patients have some of, if they have cardiovascular disease or diabetes. But it's important to remember that even if the certain types of patients with obesity do not have this, what we call as adiposopathy, they do have fat mass disease, which is degenerative joint disease, immobility, tissue compression, sleep apnea, and such, which are just by mere presence of fat cause disease, even though the fat itself may not be secreting adipokines that are detrimental to our health. So there is a number of causes. Close to my heart is the secondary causes, as I call as medications. I do sincerely believe there is a huge number of medications that we use for a variety of reasons, including chronic pain or depression or variety of psychiatric conditions that result in obesity. And also, in fact, even some things like beta blockers. It may not be that each one causing 100-pound weight gain, but a cumulative effect of a number of medications that cause 5-pound, 10-pound weight loss may eventually result in significant levels of obesity. And I think I noticed that when I asked the patients, like, why are you taking this medication? Well, I had high blood pressure, but then there are also 4 other blood pressure medications, right? So we never really take patients off any medication if that doesn't work. So it's like one of the things, we just add on more therapy rather than subtracting anything. So there's a lot of medications like gabapentin and some of the hormonal contraceptives can result in weight gain. So important to recognize those causes. And that doesn't mean that you always can take them off, but at least knowing what might be the cause. So in the end, it's really imbalance between energy intake and energy expenditure that results in obesity. And the energy intake, we have really learned a lot in the past 10 years. It's really young field and it's very, very exciting. So if you look at those red arrows, they're pointing to orexogenic factors or appetite hormones. And the ghrelin is one of the strongest one. If you see this, the third column there, anorexogenic factors, there are a lot of them. They're the ones that cause satiety and actually result in less consumption of food. But our the ghrelin is really the star of all. It's extremely strong and it results in increase in appetite, and ghrelin levels increase right before a person is gets hungry and eats. And then once food is consumed, these anorexogenic factors help the feeling of that satiety. So the ghrelin, which is secreted by the fundus of the stomach, impacts different neurons in arcuate nucleus and result in neurotransmitters like neuropeptide Y, agouti-related peptide, and they result in more second-order neuron and neurotransmitter generation, resulting in either hunger or in the satiety. So the satiety hormones, you see the GLP-1 there, but there's peptide YY, cholecystokinin, glucagon, leptin, a number of them from a variety of peripheral tissues are secreted and again result in satiety feeling in the brain. That's the food consumption portion. Now, the energy expenditure itself can be from a variety of different things. Resting energy expenditure, which varies based on a number of things, including body weight and height, gender, and hormones. But that's almost 60% of our daily energy expenditure is the resting energy expenditure. And then the top one, green, is physical activity. And the smaller portion is the diet-induced thermogenesis. So this is the energy that is expended when during the food consumption as well as digestion of the food. So the energy we talked about, so the caloric intake versus energy imbalance. So if there is a balance, the weight is maintained, and if it goes one way or the other, either weight loss or weight gain occur. So those with imbalance towards the weight increase in energy expenditure, they come to us. So what do we do? So we have to understand a few things. In fact, I say helping a patient with weight loss is probably the easiest thing. It's really the journey that starts afterwards. The weight maintenance is extremely hard. So again, the first couple of slides I showed, obesity is a disease. You don't want to say it that way, but it is a disease. When you stop the treatment, the disease comes back. So the phase 2, the weight loss maintenance phase, is extremely important. And what we believe now is that the disease needs to be continuously be monitored and indefinitely treated. I don't mean treatment is always a medication or some other thing, but the cognitive portion of it, and patient as well as the physician recognizing the ability of this disease to creep back up. So why do patients gain back weight? So there are two things. One is change in the appetitive hormones, and the other one is metabolic adaptation. So I'm going to talk about metabolic adaptation. So you may have heard patients coming, I lost weight and then, I gained back weight and some more. So that phenomena is considered, one of them is the metabolic adaptation. This is a very nice study that was published in 1995 that showed that those individuals who lost weight, 10% weight, have a decrease in energy expenditure. It stops around about 10% weight loss, but you see the resting energy expenditure is lower by about 300 kilocalories. So this is really illustrated in that Biggest Loser study, which actually showed that all the individuals, almost all, 13 out of 14 contestants, gained back weight after 6 years, even though they were maintaining the diet as well as exercise. And the study also showed that these individuals who gained back weight, almost all of them had seen decrease in metabolism after the weight loss. So that's the metabolic adaptation. So along with that, not only that, there is decrease as people lose weight, the peripheral signals of satiety go down. So particularly leptin that goes down. And that results and increase in ghrelin increases food intake. So you not only are burning fewer calories, the hunger goes up. So now it's almost like 75% of America is dieting at any one time point. So everybody is losing weight and gaining back weight. So if really weight loss, the weight loss methods that we are traditionally using worked, all these people are trying to lose weight would maintain the weight loss. So unfortunately, it's not. It's very physiologic to gain back weight. So many of my patients really go to these med spas, and before the Ozempic craze, but people would go to different places, and they would get those protein bars or this or that, and they would patients would say, oh, I spent all this money, I lost weight, doctor, but you know what, I gained back weight because I lost my willpower, right? So I gained back weight after 3 to 4 months. So if I were, they should have predicted the weight gain will occur after 3 to 4 months of diet. Every diet works, and everyone can do the diet for 3 to 4 months, but it's really when the metabolic adaptation hits, as well as the increase in appetitive hormones and decrease in satiety hormones, which happens, it has got nothing to do with willpower. So it is really the biology of weight loss. So that, understanding really helped us in the obesity medicine to empathize with our patients, right? So, it's not like anybody is thinking that I'm going to be born and I will be, 300 pounds when by the time I'm 40 years of age. So it's really, yes, there is some personal responsibility, but at some point the personal responsibility is no longer the case, and biology trumps personal responsibility. Now, I'm not saying that we shouldn't do exercise or diet, but it's important to recognize that. So there were, this is one of the old studies that literally talked about, the weight management programs that focused on weight maintenance after the initial weight loss. Patients did better compared to those who just gave patients, oh, you take this protein thing or whatever and go your merry way. So we take this to heart. So we really, in our program, the follow-up after the initial weight loss is extremely important. We make sure that they come back, and there is a huge amount of effort placed on weight maintenance. So what are the therapies? Obviously, they're dependent on many things, including where the patient is and where the patient's dream weight is, and what's the initial goal versus and weight stabilization. So, but the foundation for any therapy is lifestyle modification, which is diet, exercise, and behavior modification. So I'm going to have a couple of slides about the dietary therapy. So underreporting of calorie consumption is extremely common, which again, whether it's done deliberately or just they're not willing to admit to the doctor, or they're embarrassed. So, but that happens. And men do lose more weight than women. There is a plenty of couples come in and say, well, we both started at the same time, but, my male partner lost more weight. That's because men have more muscle mass to begin with. And so the weight loss occurs much more with the same amount of caloric restriction. Men have higher resting metabolic rate and can lose more weight. The other fact that's fascinating to me is that a lot of my patients come and tell me, well, I'm doing exactly same thing as I was doing when I was 18 or 20, but I'm gaining weight. So first of all, nobody's doing what they're doing when they're 18 or 20 years of age. On top of it, their resting metabolic rate does decline by 2% per decade. So that is, even if they were doing exactly same thing, by the time people hit 40, they have to consume 100 calories less. That coupled with the decrease in activity, so that's a lot of change. So as we age, the amount of food that we require to maintain our weight is lower. And then what type of diet, right? So is it calories or macronutrient composition? There's really no like a verdict on that. I mean, there are a few studies that show that high protein diet is better. I am a total calorie person with a moderate to good amount of protein in diet. Meal replacements, prepackaged meals, Weight Watchers, Nutrisystem, all of those work. The problem is that people cannot sustain lack of variety. People kind of after a while, just get bored. Again, as I mentioned, every diet works as long as people can do it, but many of the fad diets are unsustainable. So if there's a first attempt at weight loss, people do lose weight at about 1 pound per week if they have a 500 kilocalorie deficit. But again, after a while, after 3 to 6 months, these metabolic adaptation and other changes happen. We don't really recommend very low calorie diets because of, people may lose muscle mass, and that is more detrimental in a longer sense. So again, so the diet advice could be anything as long as they can do it. So this is one study from a long time ago now, but just kind of illustrating a little bit of a benefit of that bottom dashed line, which shows a high protein diet and low carb. Maybe slightly better than the equi-caloric diets, but with the higher carb and lower amounts of protein. So exercise therapy is extremely important. People cannot really lose weight unless they're marathon runners or cross-country skiers, but it's important in the equation for maintaining the weight loss. Exercise is expected to preserve lean body mass while dieting, because when people lose weight, our body does not distinguish between fat loss or muscle mass. Right. So people are always, whether it's a diet-induced weight loss or GLP-induced or surgery, so everybody loses both fat and muscle. One way is felt as resistant training as well as aerobic activity to preserve the lean body mass. So this is one study that showed how much exercise is required for weight loss, or maybe even weight maintenance. It's really, these are listed as met hours per week, but it translates to somewhere between 350 to 420 minutes per week, which is almost an hour a day, which is really daunting for most people. But that is for to have that weight maintenance or weight loss benefit. However, in the absence, even if people don't lose weight, there are numerous advantages of exercise, right? So even without weight loss, they can improve blood pressure, cardiovascular disease, all-cause mortalities, improved glycemic control, insulin sensitivity, and lipids and body composition. So behavior therapy is very also important. Again, just bring out concepts of hunger versus appetite. So the obesity is a result of, in the behavior therapy lingo, it's a hedonic system where people, instead of eating calories for hunger and stopping when there is a sense of fullness, there is appetite for specific foods. So there is something called an apple test. If you're hungry, want to eat something, will you eat an apple? If you're really hungry, people would eat an apple. If you're not going to eat an apple, then that is not hunger, and that's appetite. So if you want to eat, think about like pleasurable foods, so give it an apple test. And if you're not going to eat an apple at that time, then you don't need that food. So now the behavioral strategies, we don't mean that every patient should see a behavioral therapist, sit on a couch and talk about it, but we all do it in the in our clinics. It's really monitoring weight is very important. Somehow that seems like, knowing what your weight is from week to week seems to help. Goal setting, nutrition education, and meal planning, and modification of physical activity, all of those are part of our behavioral strategies that we use in clinic. Now, pharmacotherapy, again, that's the key in the current day. Obviously, recommended for individuals over the BMI of 30. Even though no insurance company or agency approves this for Asians, it should be really above BMI of 25 because of the comorbidities. So there's lots of misadventures in this arena. So it's not new. Thyroid hormone was the original weight loss drug, centuries old. And after that came a number of different compounds for weight loss, and have, for one reason or the other, they have been pulled out of market. So now we are in this golden age. For those of us who practiced obesity medicine before these were in the market versus now, it's really it has now different set of problems, but in general, we are really able to offer our patients something that it can help. So there are sympathomimetics. A majority of them work on the brain and the satiety center, decreasing food intake. And there are some peripheral drugs that act in the periphery. And there are some new ones coming out. So we are really knocking on the door for surgery. So this is so lifestyle modifications result in anywhere between 2 to 8%, and surgery between 15 to 40% weight loss total from the baseline body weight. So now, the initial ones, which are, phentermine and so on and so forth, and even liraglutide, they were still under around 10% or so. So now with the new drugs, we are almost approaching 20, 22% weight loss from baseline. So orlistat, I'll just mention one sentence and move on. This is not something that I haven't used, I think maybe in the last 2-3 years, maybe once. Other than that, this is the one that inhibits pancreatic lipase, decreases the fat absorption. So as you can imagine, there is a huge problem with the fecal fat excretion. This is supposed to work by modification of diets, right? So if you have high fat food, if you take this, there's a lot of accidents, so patients will modify their diet. However, it doesn't work for high carb diet. So you could take all the Ally or Xenical that you like, or Listat, but if the diet is high in carbohydrates, it won't work. But it's one of those that actually, if taken appropriately, does cause 10% weight loss. And it has excellent cardiovascular and safety profile. This is actually one drug that had a study that lasted about 4 years long. So, well, if it's one in the toolbox, occasionally you can pull it out. The sympathomimetic drugs, these are approved for short-term use only. The phentermine, believe it or not, is the most commonly used weight loss drug across the world, mainly because of it's cheap and lot of this is the drug that's used right before weddings and important events for centuries, and well, not centuries, decades. And in Hollywood, this used to be the drug that everybody took. And so they act by stimulating release or inhibiting the reuptake of norepinephrine, and serotonin. So they increase satiety. That's how they work. But they're only approved for short-term use. Efficacious, but side effects and a lot of contraindications. So again, because of the cost, we are really pulling out a lot of old drugs back into our fold because more and more people are coming into the asking for obesity management. So the GLP-1 agonists, which everyone wants, they are either not available or too expensive. They can only afford for so many months. Then what? So I actually used more phentermine in the recent years than I ever used before because of this. Everyone is back in the fold of wanting to lose weight. So Now these are the incretin mimetics. Really great story for incretins. If you see this panel on the left, you see that there is this huge blue area between red and black. So that's what we call as incretin effect. So what it is that when patients received oral glucose versus IV glucose, it was observed that the amount of insulin release was much higher when oral glucose was given. That black line is the insulin secretion after oral glucose. The red line was when IV glucose was given. We know that glucose is 100% absorbed, and it wasn't, and the same amount enters the circulation but we didn't know why this these people who consume oral glucose had such high increase in insulin. And that was called incretin effects. It almost took another 2 decades to identify what those incretins were. And they were GLP-1 and GIP. And also some studies showed that patients with type 2 diabetes had this reduced incretin effect. So it's almost like a incretin deficient state or incretin resistance, like insulin resistance. Patients with type 2 diabetes had less effect. So that's where the journey of these great compounds began, and they were investigated, and they are these hormones that are secreted by gut K and L enteroendocrine cells. And then, they increase insulin production, decrease glucagon, and increase satiety and appetite secretion. So, initially GLP-1 was the only one that came into the market, GLP-1 agonist, which is semaglutide. GIP itself, in original studies, did not really show any benefit for diabetes improvement. So it kind of fell off. Like literally for a decade, we only talked about GLP-1. But the new compound that was a dual agonist showed much more promise. So these are the 3 GLP/GIP agonists now in the market: liraglutide, which goes by Saxenda; tirzepatide, which goes by Zepbound; and semaglutide, which goes by Wegovy. So the liraglutide average weight loss is 7%. This is a daily injection. About 56% lost 5% and 28% lost 10%. So again, with minimal side effects, this was really a great news for us and improved diabetes in patients with diabetes. So it was really the first drug of this class that showed significant benefit. And then the semaglutide came on the market and showed almost like a 17 to 18% weight loss. That's that first panel in the showing the BMI reduce, and almost over 50% lost 15% or more of body weight loss. And also showed that if you see that panel C, the percentage of patients that actually lost the weight. I did mention all of these studies had lifestyle modifications along with the placebo. So you can see some patients in lifestyle modification/placebo group also lost weight, but the numbers are much lower. So if you look at 20% weight reduction with semaglutide in this panel C, 40% lost more than 20% weight, and about only 3% in that placebo group. Now the twincretin, this is the new kid on the block now, Zepbound, which is an agonist of both GIP and GLP-1 receptor, showed 22.5% weight loss with its maximum dose of 15 milligrams. And about 63% lost about 20% of body weight. So it's pretty remarkable. Nausea and vomiting are the side effects. There are serious but less common. Pancreatitis is one. I have another slide about it. There's a slight increase in signal. Suicidal thoughts, literally, I think a couple of weeks ago, a paper was published that it's no longer I should update the slide. So they did not see after a number of years of follow-up that there is increase in suicidal thoughts. Now, those of you who see the ads on the TV, this medullary thyroid cancer, MEN2A, features prominently in every ad of GLP-1 agonists that we are not supposed to give them. Again, this is all in rodents. They have not been reported in humans, but we do avoid in patients who have medullary thyroid cancer or some types of multiple endocrine neoplasia syndromes. So the combo drugs, some of the older ones came in as combo. So phentermine, we talked about 8 to 10% weight loss in the past. And then topiramate. So this is a drug that is given for seizures, chronic pain, and it was observed that patients were losing weight. So by itself, it causes about 3% weight loss, topiramate. Every drug that is currently approved for weight loss needs to show 5% more weight loss than placebo. So by itself, topiramate will never get weight loss indication, but together with phentermine, it does result in 8 to 10% weight loss. There is a dose escalation. There are 4 different doses. And again, it has some contraindications and stuff, but all in all, people do tolerate a little bit more effort needed from the provider and the patient, monitoring the heart rate, blood pressure, and especially for topiramate, we do take their blood work, initially after 2 to 3 weeks after starting because of hypokalemia, non-anion gap acidosis. So those monitoring needs to be done at least initially until patients reach a steady dose. And then Contrave or bupropion naltrexone combination. Bupropion itself is a antidepressant, again observed to have weight loss when used for depression. And when combined with naltrexone, naltrexone by itself does not have any weight loss effect. It just compounds the effect of bupropion in the arcuate nucleus in POMC neurons. And again, bupropion itself causes maybe 4% weight loss, will not get a weight loss indication. But in combination with that, it does result in 7% weight loss. And there are a bunch of contraindications and things like that. So, but again, we do use it sometimes when the cost becomes an issue. So the GLP-1s, semaglutide, liraglutide, in this particular research letter did show that when compared to the other weight loss drug, there is a signal for pancreatitis and some other GI side effects. So that needs to be, explained to the patient, and we also take into consideration that if patient has a history of pancreatitis, especially idiopathic pancreatitis, we do not start them on medications. But if there was a cause for pancreatitis, like for example, a defined cause, patient alcoholic, absolutely now abstinent, or if a patient had high triglycerides, now again treated, or gallstone pancreatitis, so we do cautiously start the patients on the medications. So I want to just make it a point, if any of you are in any kind of regulatory agencies and stuff, at least in Wisconsin, our Medicaid program covers for 1 year. Many of the employers cover the drug for 1 year, and it's absolutely useless. They might as well take the money and throw it out of the window, or I don't know, wherever you can throw money out into, you can do that, because the weight will absolutely come back. There is a very small group of patients that actually do maintain the weight loss if they are off the GLP-1 agonists. So you can see each one of those graphs showing that the patients gain back weight. In fact, almost 5 to 6% within the first 3 months. So this is our biggest challenge now. Even patients who want to buy the drugs based on, if they want to buy it paying, I want to get a head start and stuff, it's really hard. So we are coming up with a variety of different options and how to keep people on once they have received it. So This is kind of a fun graph. I have two of them. One is an older one. This is comparing weight loss efficacy on x-axis versus adverse events. And if you can see that, the weight loss efficacy, higher side effects. So these are all kind of in here. You can see at some point, back in 2015, 2016, liraglutide was really more efficacious and less. So if you now look at the current day, this one doesn't really even have tirzepatide, the most recent one, but liraglutide is here. So the semaglutide, again, a lot more beneficial in terms of side effects versus weight loss efficacy. So what is coming up? This is not yet approved. It's in the pipeline. It's a triagonist, GLP, GIP, and glucagon. So in phase 2 trials, it showed about 22.2% decrease in body weight. And about 48% of people lost 25% of body weight. This study is expected to wrap up next year. But the side effects were also high. So again, it's somewhere, some areas I've seen it as 20% or so as patients unable to tolerate. But looks like if 80% can tolerate and can achieve about 24% or more weight loss, this is a pretty good deal. So the new thing here is the glucagon agonist. So glucagon sort of expected to increase some resting metabolic rate, and so that's giving it additional oomph that we have seen from GLP versus GIP. And also it improves hepatic glucose production, so will be very helpful for patients with diabetes. So this triple agonist is coming soon. And then this is the oral GLP-1 agonist, or forglipron. So this is a non-peptide small molecule. So the GLP-1 agonist, GLP-GIP-1 agonist, they are peptides. So they are large molecules, and except unless it's really modified, you cannot give it orally. They already are oral versions of GLP-1 agonists, the peptide ones. I didn't talk about it because they're only approved for diabetes. But so this one, it's not a peptide, so you can take orally without any modifications, and has some adverse effects, but has shown in the phase 2 trials about 14.7% weight loss. And again, about 50% showed 15% or more. So this is expected to be sort of a game changer because it's not a peptide, sort of easier to make. So a lot of GLP-1 agonists, even though there are a lot of compounded ones, but they're not that easy to make. And it requires a device that it's needed to deliver, whereas this is a pill. So hope that maybe the cost would be less, and this would definitely be welcome compound, hopefully next year or so. So again, just to kind of summarizing these ones that we are now using, retatrutide is about 22% weight loss. That's the maximum. And with about over 80% seeing 15% or more weight loss in those phase 2 trials. Whereas tirzepatide, again, pretty comparable. And so we will have a lot more to choose from going forward. So what about all these other things? Like, they don't work. So there's still, there are a lot of people that are using these compounds. I always tell my patients if there is an ounce of truth to any of these compounds, there will be a big pharma trying to, capitalize on them. As you can see, each of these drugs have upwards of $500, the GLP ones, or around $500 now, direct to consumer. So they're not going to sell these bottles and for $40 or $50. So you can just say that they don't work. So I wanted to leave plenty of time. And I think I don't know, maybe I shouldn't say typical, but I talk fast. So I figured today I can talk fast because we're in our Desi community. Because if for an American audience, I have to be slow. We speak fast. I don't know why we do. We speak. I think we think in, for me, I think in Telugu and then I speak in English. So I guess so. But we have plenty of time for questions.
No, thank you. Thank you. Yeah, this was really good. And yeah, again, I think more the time we have for questions, the better it is, because I'm pretty sure there are a lot of people and a lot of questions, and this was really a good talk. So I'll let Preeti start to talk about these things, and if she has any questions as well. Yeah.
Sure, sure. So thank you so much, Vidya, and everybody else that's joined tonight. As I was writing down my list of questions to ask you, I can see there are a lot of good, really wonderful questions coming in from the audience. So I'm just going to sort of start from the top and go down the list. The first question, I think, speaks to the pathophysiology of obesity. And Dr. Shukla is asking, is it obesity or chronic inflammation? So I guess if you can comment on perhaps whether it's chronic inflammation that's the main culprit for metabolic problems, or is there a role of chronic inflammation in the pathophysiology and pathogenesis of obesity and obesity-related complications?
Probably both. So the more well known is that in patients with obesity with ectopic fat, there are pro-inflammatory adipokines. We know that all the metabolic diseases as well as obesity is a pro-high inflammation state. So obviously that implies that obesity is the cause of the inflammation and so on and so forth. But there are some thoughts that there is probably inflammation is cause of the obesity, reduction in satiety or increase in hunger in a variety of central structures in terms of in the arcuate nucleus. So there could be some role of causing, but that's not well known. More, it's the obesity is causing a pro-inflammatory state. And maybe that in itself, insulin resistance, some people believe if insulin resistance is a result of um, um, the ectopic fat, and that in itself does high insulin cause increase in appetite. So there is some pathway there. Again, I think probably not as well studied in terms of me to say definitively, yes, this causes that.
Excellent. So again, another question that targets a little bit of the pathophysiology that you so well described towards the beginning of the talk. One is, one question I had was about metabolic adaptation and set point. Do we have anything that can change the set point? And the question from Dr. Dave, if I'm saying all the names correctly, is there metabolic adaptation by the body after taking weight loss drugs for a while?
So the set point is a topic that's, some are big believers in set point, thinking that, there is a certain body weight we defend, and, what moves the set point down. So there are big believers that the weight loss drugs do move the set point down. To me, they are very cogent arguments, but do I have experimental evidence it's moving down or moving up? So practically in clinic, I'm not seeing any change in set point. Our organization covered weight loss drugs for 2 years. People lost tons of weight. And they said, well, after you can get a lifetime coverage of 2 years. I'm telling you, I've seen maybe one out of my 20 patients that I've seen in the last few months that had finished that has maintained the weight. So I don't know how long do you have to give these weight loss drugs to move that set point down? I am not sure. So again, it's really hard to know. And again, how long do you have to have obesity to have that set point to defend it? So it's kind of hard to know. So some of these are really good academic discussions, but I don't have a practical evidence to defend the set point theory. What did I miss, Preeti? I'm sure I missed some
No,
part
no,
of the question.
that was good. The question was really about whether after taking weight loss drugs for a while, can we
Yeah,
have a metabolic adaptation so that you can defend a lower body weight? So I think
yeah,
you kind of got to all the points. Um, I think one of the things that we see a lot in our weight management program is that um, there's a huge psychology for weight maintenance and weight management. And, even without drugs, patients will lose a lot of weight because of the accountability. I think we could call them and talk to them about the weather once a week, and maybe we'll see some weight loss even just from that. So there's a huge psychological component to it. And I think one of the things that is very appealing in this whole hypothesis for me is, if you give drugs for, let's say, 2 years, 4 years, 5 years, and people sort of get used to the new way of eating, they learn to eat smaller portions or eat different types of foods. We know, of course, that these drugs are also changing some of the hedonic value of food. For example, alcohol or high fat food, you kind of develop a distaste towards some of these things. So I'm just wondering, and of course, I don't have any evidence, but I don't know what your experience is with that. Have you seen, I mean, of course, most patients regain weight once we stop the drugs. We have short-term data on this. But we don't know what would happen perhaps, longer term if we used for maybe 5 years or more.
yeah. So definitely the taste for food changes. One of the common things people are, they no longer enjoy the pop or soda, things like that. And no, I mean, alcohol consumption definitely it's being really actually being evaluated for alcoholism, right? So several NIH studies, we just had a speaker from NIH, I mean, really elegant studies. It's probably will some form or the other will become actually a drug for alcohol, for abstinence. So there is definitely some change in taste. Satiety improves, food noise goes away, and people actually think, right? So it's instead of eating everything, because the hunger is not so high, people are able to kind of sit there and think about it, right? If I give them the Apple test, they can do the Apple test when they're on GLP-1 agonists, So there's definitely that, yeah, we would love to know exactly how long, because this is something that I'm fighting with everybody that will listen, that are in the positions of power, that would say you can get it this long or that long. But it's as we talked about, these are the drugs that it's like you would never have discussed for diabetes. Oh yeah, I'm going to give it to you for 2 years, or for hypertension, stop it after that. We would never have had those discussions. I mean, it is kind of unconscionable if now to think, say, okay, you know what, you can try it for about 6 months and come off of it. So, but I believe it's not in coming from any malicious place. They're doing what they can, which is because these drugs are extremely expensive. So I am really, really hopeful. This place we find ourselves in, where who are we going to give? Really, we are like almost have this power, who can get it and who don't, right? But I'm hoping that this will improve with oral GLP-1s and all the others coming into the market. So there could be something that we will see in about 4 or 5 years from now, that everyone who needs it can get it.
Yeah, so I agree. I think we need 100% lot more data, on maintenance, and maybe giving it every other week or
Yeah.
something like that. That would all be wonderful. I don't think the pharmaceutical companies are going to do those studies, so hopefully some of us will be able to shed some light on some of these longer term things with related to GLP-1 agonists. So this group is like amazing group of physiologists, I think. Look at all these questions. So, goes straight to my physiologist's heart. Here we go. So here's another very fun sort of question. What is your view on low carb diet to lower insulin levels, stimulate lipolysis as a weight loss strategy? As we know, like our traditional approach of calorie in or calorie out is not seems to work so well. is there, how does dietary fat intake impact weight gain?
So the low carb diets work. And in fact, it's among all the thousands of types of diets that exist. I think that's probably one of them that actually is probably sustainable. Maybe, somewhere between Atkins to keto, not such high. So there are definitely showing that they have a somewhat more benefit in weight loss and weight loss maintenance and sustainability of diet compared to usual carb or high carb diets. So there's no question that they would be beneficial. High protein diet comes with its own set of naysayers, right? Different things like kidney stones and things like that, and whether the high protein is now animal protein versus plant-based protein. Will that increase, cancer incidence? So those are all the questions that we have to. I am of the opinion eat everything, but in a moderation. I think the kind of things that's coming from along, because anything too much is not good. I think in so the amount of protein these young kids nowadays are consuming, I don't know how good it is because everyone is on high protein bandwagon. Whether it is in itself, so protein itself is actually a stimulator of insulin release, right? So in fact, there is some thought about if insulin is bad for you. In fact, there was a paper, I think, from Kevin Hall that these high protein bars and things like that, they are intermittently increasing insulin release and maybe not so good for you actually in the end. Now, again, what I would say is that it's really always some moderation, somewhere maybe not like usual diets of 20% protein, but maybe somewhere between 35% protein and, not like 200 grams of carbohydrates as most of us Indians are used to, somewhere between around 100 to 150 grams of carbs per day is probably sustainable in a long term, and also avoiding that very high amounts of animal protein because the verdict is not out yet. Well, I shouldn't say verdict is not out. America has such high prevalence of cancer. Whether is it from really high protein animal-based products or what, we don't know yet. So again, food science is a very, very imperfect. And you can find evidence for any statement people make. And there is so much people writing with absolutely zero evidence. And also studies are extremely hard to do. Like, I mean, to say high protein is good, low protein is good, what we have, like 14, 16 weeks worth of studies. We are not talking about studies that, okay, what happens if you consume very high protein diet all your teenage years or early, I don't know what happens because such studies don't exist. So, yeah, so I don't know if I answered your question, but it's really the cynic in me. Too much of anything is not good.
Right. I think that's an excellent question, and there are definitely studies that you can find, as you mentioned, that can support one hypothesis, and this hypothesis about lowering insulin levels, increasing lipolysis, definitely has one very strong group of physicians who support it. But I think a lot of it needs to be really studied more rigorously to be something that we can recommend, on a broader basis. So it looks like we're sort of out of time, but it's up to Dr. Govil to decide if I should continue because there are some really nice
I think, yeah,
questions.
if you can quickly summarize a few questions because some of them may be
Very high
overlapping,
level.
but we can
Yeah.
take like
Yeah.
another 5 minutes worth of, yeah.
Perfect. So I think let's go to pharmacotherapy side now. There are several questions about physiology, but you've answered a lot of those. I think something that's like a very practical question is, what techniques have you found that help you get insurance approval for your patients? Yeah.
Can I talk about this? This is a CME program. I have lots of lots of, necessity is mother of invention, right? So without outright lying. So early on, the insurance companies caught on, but I used to start everybody on metformin. So, you would do GLP-1, right? It would it won't get approved. So I figured out after metformin, some reason maybe they thought that metformin could be used for diabetes. So I had a golden age of 2 years, like before Wisconsin Medicare and Medicaid discovered that we were doing that. So we got really good approvals. So that's one. So the other, obviously the Wegovy, that semaglutide, is now approved for cardiovascular disease. So Dr. Govil stopped me if I'm not supposed to. So now I do. So I do a bunch of things. So if at all, so I find if they have cardiovascular disease, I've been doing a lot of ABIs, believe it or not, because ABI under 0.8 is considered cardiovascular disease, and you can actually get Wegovy covered for that. So I'm doing a lot of glucose tolerance tests. One of my favorite statements is, I'm really, really sorry you don't have diabetes, because if you have diabetes, GLP-1 gets covered. So oral glucose tolerance test is a lot more sensitive than A1C, right? So someone who's in 6.2, 6.3 range. So I've been doing glucose tolerance tests. So give them a diagnosis of diabetes. But technically, to be correct, you have to have 2 glucose tolerance tests that are abnormal. So if they get the diabetes diagnosis, of course, that's one thing. If patients have had bariatric surgery and had diabetes before, but no longer have it, I don't feel like I'm lying. So I do use diabetes diagnosis. And of course, a lot of sleep studies now after Zepbound was approved by by Medicare for, that's a tirzepatide approved for obstructive sleep apnea. So, but the sleep apnea, hypopnea index has to be over 14. So you order this test and pray to God that they have AHI over 15. So so that's what happens. And then we obviously now NovoCare and LilyCare both have launched direct to consumer, right? So you would have the tirzepatide 2.5 milligrams for $349 per month. And then up to 10 milligrams is about $499. So much better than before. So we do that, and we try to do, as they get to higher doses, maybe do 1 in 10 days or something like that, once in 10 days. So you do have to fill that medication, Zepbound, every 6 weeks. So, but $500 every 6 weeks or so. And Wegovy also is $499. The problem with Wegovy is that Medicare patients cannot get that, because there is some way Novo Nordisk and Eli Lilly are doing are different. So Zepbound can be given to Medicare patients. Medicare patients can get, they don't have to have any comorbidities. They are paying out of pocket, but the company itself is selling it for $499. But Zepbound, Medicare patients can get it, whereas Wegovy, Medicare patients cannot get it because it's a different coupon type of mechanism. But again, so trying to find cardiovascular disease, the cardiovascular disease indication for Wegovy, it's not coronary calcium score. So there are a lot of patients that are coming in, they're getting these CAC scores, and they say, well, that doesn't work. They have to have either a heart attack, or they had to have stent or cabbage, or a stroke, or ABIs under 0.8. So so I don't know. Those are our techniques. So.
Yeah, I agree. Some of these things have actually definitely made it a little bit easier to get GLP-1s approved, but it is always challenging, requires a lot of prior auths. There's shortages, there's all kinds of problems in helping people continue. There are several comments and questions about the role of lifestyle change. And I think, as I had mentioned earlier, we do see a huge benefit in patients who do incorporate dietary changes and exercise. It's one of the cornerstones in our obesity medicine practice. So it's not just all about drugs. We do behavior modification. We talk about stress reduction. Many things that are sort of like talked about in lifestyle medicine, we also practice in obesity medicines. So could you comment on lifestyle change and where you see the value of that?
So almost all the studies have had that as a background. So it is absolutely key. for diet and exercise and behavior modification. So we do spend enormous amount of time going over that. So there is really no other way about it. So we also see patients as frequently as possible. So, you know, some of the earlier studies, they said like 16 visits or something. We can't do 16 visits. But at least it's not writing the prescription and having them, okay, you know, see you in 3 months. So we at least try to see them every 4 weeks early on, especially as they're trying to get to, you know, the maintenance dose. And even after that, again, as we do consider this as diabetes or hypertension or something else, it's never that, okay, you know, you're doing this and see you, we cannot. So that's that the problem with that is that then we cannot see a lot of new patients. So we have thousands of patients waiting like every obesity program, but we do our best. And really the follow-up and that hand holding is extremely important. And I cannot emphasize that enough.
Okay.
Great. Wonderful.
I guess we have, yeah. The only one interesting thing I saw was herbivores, carnivores. You want to bring that up? That's interesting. I would want to know.
Sure. I think, yeah. So there's a question from Dr. Shukla. Why herbivorous animals are obese and carnivores are thin if fat is the issue?
I mean that, so the dietary fat, you mean?
Yes, I guess, yes.
You're talking about different groups. I mean, you know, the cows that don't run, like, you know, carnivores, like gazelle, if you're talking about, they probably run, exercise, and even though it's high in fat, they are doing highly muscular, I would think. Yeah, it's very, very interesting, but I don't think we are really comparing apples to oranges. They're not comparable. If you put the same gazelle on a herbivore diet and carnivore diet and then see, that's different, right? So I don't think cows eat meat, or, you know, the cheetahs eat grass. So we don't have data on that.
Great.
Yeah, and the lifespan may be different as well, somehow, I would think.
Oh
Something,
boy, you guys
obviously,
are
these
putting
are
me into
all
zoology. I don't remember. I don't know how long. I don't even know how long a cub lives. Does anyone know? I don't-
15, 20, I think 20 years or so.
Oh,
And
is it?
in
Okay.
my mind, somehow I feel the carnivores live less compared to the herbivores.
Oh,
Just, yeah,
boy.
just
I guess
again,
dogs and
without
cats.
any
Yeah, dogs about
scientific
12,
basis.
16
So,
years. Yeah, no, I don't remember. Yeah, so, but they're very different groups, even though they're all mammals. I think just very different, right? So what they do and the purpose of them, and you know, the carnivores, they have to run to get the that animal to eat, whereas the plants don't move. So these herbivores are like stationary, like, you know, they can sit
grazing,
there and eat their graze.
they graze all the
Whereas,
time.
yeah,
Yeah,
so
that's
so
what.
they have, yeah, they have different sets of muscles developed, and I would think that plays a huge role into what it would be. So,
No, thank
Yeah,
you.
so they have to hunt, and then they might have one kill in 3 days.
Yeah,
So then they have, I guess,
yeah,
mandatory intermittent fasting. We didn't even talk about that topic because that's a whole another topic.
intermittent fasting is, yeah.
yeah,
Okay.
each one of us have an hour-long discussion that we
Yes,
have.
no, no, no.
So,
We'll leave it for next time. But thank you, everyone. And Dr. Katula, are you on to present that? Let's see if he's there.
I see him.
Okay. And yes, he's logging in. Vijaya, can you? You're on the mute, Dr. Katula. You need to unmute yourself, Satish. Let's see if we can.
Okay. Now I'm
Yeah, now we
unmuted.
can hear you. Yep,
So
go ahead.
yeah. All right. So thank you, Dr. Kidambi. That was an excellent talk, and thank you, Dr. Preeti, for the moderation, and Dr. Amit Govil for choosing this very appropriate topic, which is very very important, and all the audience for being here tonight. I just want to make an announcement. We have another CME this coming Sunday, May 25th, from 11 o'clock till 12:30 or so. It's imposter syndrome, and it is delivered by Dr. Divya Kochar Navani from Orlando, Florida. She's the Women's Forum chair, and she'll be talking about imposter syndrome, and it's for both women and men. So please join on May 25th at 11 o'clock, 11 a.m. EST. And we have a token of appreciation for Dr. Kidambi. So Vijaya, could you please, yeah, it's actually projected there. So let me look at that. And American Association of Physicians of Indian Origin recognizes Sri Vidya Kidambi, MD/MS, for her outstanding contributions in the field of endocrinology and welcomes her as a member of AAPI Distinguished Speakers Club. Satish Kathula, AAPI President, Amit Govil, Chair, AAPI CME Committee, May 21-25. So thank you all for joining today. Thank you, Dr. Kidambi, again for giving this excellent lecture. Thank you.
Yeah.
Thank you.
Thank
Thank
you.
you for
Thank you
having me.
both.
Thank
Thank
you,
you.
Preeti.